Well, hello and good evening, everyone. Thank you so much for being here for another webinar with us, getting to learn more about yourself, about your genes, about all the wonderful things that you can do to help optimize your health. So tonight we are going to be talking about pharmacogenetics, really getting down to the basic understandings, taking a look at some of the main genes that are looked at, how they work, and how this affects you. Why is this even important? Why would you want to know? So we are going to be introducing you to our PGX, our pharmacogenetics test and what it entails, as well as how some of the information from your DNA 360 reports also reflect in and can give you information on how pharmacological agents, drugs, okay, will work with your system. And I have the delight and honor to be co-hosting with our frequent offenders, Justin Harris and Dr. Stephanie Nielsen. Hello and good evening to you both.
Hello, hello. Good to be here. I'll say that one of my favorite things about this topic is that when you kind of dissect the term precision medicine, nothing is a better example of that than PGX, right? Like the Pharmacogenomics report. It really takes what mainstream medicine does and it whittles it all the way down to what is the most appropriate. We know that genes have a large impact on how your body metabolizes medications. I mean, medications have to be metabolized just like anything else does, right? Just like hormones do, just like neurotransmitters do. Enzymes are what do that whole process, right? So, considering the fact that genes encode enzymes, and by testing your genes, we're able to see what the different like speeds of these enzymes are, right? So, if you have a particular enzyme associated with the metabolism of an anti anxiety medication, well, if we know the speed of the enzyme, then we can see if you're over or under metabolizing such a thing. And if you're at an appropriate rate of metabolization, then you're going to have the least amount of side effects. And it's also going to do its job, right? Because if you don't metabolize it properly, it might just not be efficacious in the first place. And this report can absolutely save your life. You know, like medication can save you, it can also end your life if you do it improperly. So, diagnostic tools are so important with this, and I'm really glad that this exists because it might just save a whole lot of people's lives. Hello, Dr. Nielsen. Good to see you here as well.
I'm sorry, I ran downstairs and I thought I had a minute more. Dogs and animals and all my critters. I apologize.
You're all good. And actually, excuse me, this gives me a moment to ask our audience to please fill out the poll. We really like to have this information to know whom we're talking with, who is here absorbing the information, what is important to you, and how can we help serve you even better? What are your interests? Really, why are you here tonight? Because we are so thankful that you are. And we wouldn't be here if it weren't for you. So please fill out the poll and we'll be going over the answers in a few more minutes. So one of the things with our PGX, so again, what is our PGX test? So our PGX test actually stands for pharmacogenetics. And really what it does is it's looking at your DNA. And yes, it's another DNA test, works with saliva, really to understand how your body processes drugs, okay? It doesn't do supplements. It doesn't look at drug-to-drug interactions or anything like that, but how specifically your genes work with specific drugs, including things like antidepressants, antipsychotics, anesthesia. So even if you don't take any medications, heaven forbid you should be in an accident and need surgery, or something happens and you need surgery, well, guess what? They're going to give you medications. They might have to put you under, which is going to cause the need for anesthesia. And wouldn't it be wonderful if you knew ahead of time if your genetics predisposed you to a situation where certain anesthesia medications would not be efficacious for you. They wouldn't work so well. They might not put you under as well, or they might cause more problems on that surgical table than the doctors were prepared for. So knowing this information can be very useful, even if you do not take prescribed medications regularly. So, and I do have a lot of clients that come to me, with their PGX reports and say, well, I don't take any medications, but I figured it would be a good idea to know just in case.
And here's another area where it comes in handy. DNA doesn't change. So as we age, you may need to be put on medicine, or with the incident of dementia and Alzheimer's. If people have been watching for the last several years, they know that my father has Alzheimer's and Parkinson's. He is no longer able to give verbal responses about if things are working or not working for him. And let me tell you, the polypharmacy that happens in geriatrics and with someone who can't articulate, I am so thankful that we have a PGX. So when they say, I want them on a blood thinner, I want them on an antipsychotic, I want them on an antidepressant, I wonder if he should be on a pain medicine, I can pull out his PGX and say, this one's going to work for him, this one's not. We have the best likelihood of doing this. So if you have any dementia in your family, if you have any incidents of Alzheimer's, if you yourself feel like I'm not as sharp as I used to be, and you're concerned about that long term, what a great prevention now, so that you have answers when you can't give answers. And the same thing goes for autistic kids, nonverbal autistic kids, anyone who's nonverbal. You can get that information now, and so that if they need to be put on things, you have the best fighting chance.
That is so important, because we take for granted a lot of times our regular situations and, for us ourselves, okay? Know how we feel, but if we are not able to truly communicate, wouldn't it be nice to have an advocate have that information? And also as a caretaker, it really is invaluable. And like I said, as far as the PGX test, there's no major thing that you have to do. It is very much like the DNA 360 test kit. It's designed for the convenience for you to do at your home. Basically, you just receive the kit, you look at the instructions, take the collection sample. It's either saliva or cheek swab collection. You follow the directions, put it all back, mail it in a prepaid packaging, making sure that you're using the right mailing, which is usually FedEx, I believe. So double check that. So if it says FedEx, don't bring it to the post office. And then you'll have that, fairly quick and easy, hassle-free response. And, it generally takes about 4 to 6 weeks for when you actually do your sample, when you send it out and it's received at the lab, and then you generate your results. And then, of course, you can always get a review of that test through one of our practitioners. So very simple. And the nice thing is that we are currently having a $200 off coupon for our PGX. So Vanny will actually put that coupon code in the chat. So it's PGX 200 at checkout, and that saves you $200 off the PGX test. So that is going on now. So if you are interested, you can go right to our website at thednacompany.com and put in that code.
It's a lot less invasive than most preventative screenings if you actually look at it, right? Like, I think that mainstream medicine, there's a lot of different ways that you can do these preventative screenings for breast cancer or what have you. Most of them require you to drive to the clinic, right? And then you may have to strip down or whatever it is. But we're really used to this idea of preventative screenings. But when it comes to medication, it's like this almost Wild West approach with a lot of practitioners still. And, we know that medical error accounts for a lot of deaths, like 7,000 or something per year in the United States. So every couple of minutes, someone is unfortunately passing away because they were prescribed something that just didn't work with their biology. But within that same category, there's likely a few of them that do, or at least are a lot more likely to work with your genes and your biology. So this is an invaluable document that just all you got to do is spit in a tube and send it away, and it might just have serious value to you later on in life.
Well, and you wouldn't believe how many of our patients end up having side effects. And I want to say right now, there is no such thing as a side effect. They're all direct effects. They're just not the direct effect that it's marketed for. And with that, why don't we look at our poll? Because we can see how many people are dealing with side effects and maybe help them with something. Oh, love this. Oh my goodness, this excites me. As the pharmacist here, I'm going to tell you, we got lots to talk about. All right, Larry, do you want to do, Dr. Martin, do you want to do this, answer these, or do you want me to start them off?
Honored. So our first question is, have you ever had a bad reaction to a medication? And well, more than half of you, so 56% said yes. Guess what? I'm on that list too. So thankfully, 35% of you said no, and 9% of you said not sure. So again, what Dr. Nielsen was talking about is that any, effect, is a type of side effect, that it does things, but a lot of times we don't realize that some of these symptoms that we are having are related to the drugs. So, education and empowering yourself with the knowledge of what is going on, what are you actually taking, what have they found side effects to be? Because I will tell you, when it comes to pharmaceutical drugs, the years, the decades that go into going from benchtop research through clinical trials to being on the shelf, and then post-clinical follow-up and research, quite extensive. So they are aware of
Generally,
yes, you're up.
generally.
But there's enough to get an idea on side effects that could be happening. And it's also something that you want to retain your agency, or take back your agency, to be able to talk to your doctor, ask those questions, say, hey, this is going on. Is this typical? Why would this be? So
I'll tell you that a lot of prescribers, and I don't like to use the word doctor because we have PAs, nurse practitioners, even pharmacists are prescribing. When I got my pharmacy degree almost 40 years ago, I could prescribe, and now we're starting to do test and treat again. So I don't like to use the word doctor, but a lot of prescribers, they have habits just like everybody else. What do you eat? You have your habits. When do you go to bed? You have your regular. They have their habits of prescribing what they're comfortable with. Now, does that mean it's the best for you? No. And one of my specialties is BHRT. And I can tell you that some of the local OBs, they have one hormone cream that they prescribe for everyone. So when I challenged that prescriber on that, and I said, everyone does not need the same. He said, no, but I wait for someone to have a reaction before I change it. And I can get a 75% off the bat with my one thing. So I stick with that. If you don't complain, I don't change you. Now, I think that sucks. I think that sucks because we're all individual. Our DNAs are different. If you have a PGX, you can go in and say, I have, this, can you work within this? And the format of it is simple enough that they can say, oh, you need a statin. And I see that you might do, it's not absolute, but you might do better on these two than these two. And maybe they're used to doing one of them, but they see that you would do better on another. That's usually their second or third choice. You might actually get to avoid that guess as guess can, kind of like Justin was saying. It's kind of like Wild West, throw it, see if it sticks. And most people will not come back and complain because they still have this doctor God complex. Well, the doctor said. So they'd rather suffer through. But I want you to remember your prescriber works for you. You have hired them. You can also fire them. You have hired them for their knowledge, and they have great knowledge, but they don't know everything. So if you're equipped with knowledge and they're equipped with knowledge, and you put the two heads together, you have a fighting chance to actually have a better outcome. And so when I see our second question is 74% are currently having a problem, this is exactly what we're talking about.
Well, actually, it was 74% are not.
Oh, not. Okay, you're right.
But the fact that 12% are
Yeah.
and 15% are not sure,
Yeah.
that's still
That's 25%. Yeah.
Exactly. So, and I love how you have said in other webinars that every person has a PhD in themselves.
Right.
You are living in your body 24/7. You're the only one doing that. So we need to learn how to be in our bodies, to be able to recognize and feel and know those shifts that happen when things are out of kilter, and to be able to voice them, to describe them. So, this is where taking that agency back, as well as being able to go to your doctor. And like Dr. Nielsen said, put your heads together, work as a team. So
yeah, well, and there's also certain areas where the trial and error process is even more dangerous. Like, for example, when it comes to mental health, right? And we're talking about antidepressants, and you look on the side effect list, which to Dr. Stephanie's point, it's an effect, not a side effect. Some of them cause suicidal thoughts or actions, right? And some people don't have that year-long process to decipher which medication is going to work best for them. If they're at that point where they actually need pharmaceutical assistance for a psychiatric issue, man, that trial and error thing is way more dangerous when you're talking about suicidal potential, So just again, a guiding document to know, okay, well, this one's going to give you the most benefit, the least amount of potential poor effects. Man, that's worth its weight in gold.
It is. It is.
absolutely. So our third question is, did you know your genes affect how you respond to medications? And wonderful to see. Yep, I'm very familiar. Almost 30% of you. But the rest of you, you've either heard of it but don't know much, or that it's new to you. So welcome. I am so glad you are here, because you really are going to get a masterclass in this Pharmacogenetics 101 webinar, at least to enlighten you enough, maybe to ask some more questions, or to be interested enough to know or want to know, how do your genes affect any medications you're currently taking, or that you might be exposed to or take in the future. So our fourth question is, what type of medications are most relevant to you or a loved one? So I'm sure that everyone knows someone who is taking a medication. And unfortunately, it is one of those things that they have said that for every decade you are of age, that's how many different medications you are taking. And unfortunately, that tends to be true for the majority of the population. And obviously, we would like you to not have to take any, but, or at least take as few as possible, to be as healthy as you can. But where it is necessary, it is necessary. So for the different medications, and we have several listed here, and it looks like the most are in the cholesterol meds, statins, which Dr. Nielsen has already commented about. And we are going to dive a little bit more into that. She's even going to talk about a couple of case studies, some people that she has worked with, and the nuances of that. And then followed up by painkillers. Yeah, that's a tough one. The chronic pain situation, I am very familiar with, because I have dealt with chronic pain, back pain, due to a car accident. I was on painkillers for almost 15 years. I don't take them anymore, but I'll tell you, it is rather rampant. And Pain is difficult. So I'm not surprised that that's high up there. The next runners up are antidepressants and birth control hormone therapy. So Dr. Nielsen, right up your alley with the hormone therapies. And then we have blood thinners and then ADHD medications. And then it's nice to see 29% of you said none of these. Of course, it doesn't cover all of the particular groupings or types of medications that there are, but those are definitely some of the most common. And then our last question, would you be interested in taking a pharmacogenomic test? And 35% of you said yes. So, well, there you go in the chat. We've got that $200 off. 53% of you said maybe you need more information. Well, we hope that today's webinar will give you enough information to pique your interest enough to look into that, and then offering you that $200 off. And then 12% of you said no, which is perfectly fine. We are so glad you are here to accumulate more information. And if and when you are ever ready, we are here to help. So thank you very much for filling out that poll. So as we are speaking into pharmacogenetics, well, one of the main components is the genes themselves. So there are a lot of genes that affect pharmacological, basically drugs, their metabolization. And there were a few that we looked through that we wanted to highlight simply because of the percentage of medications that they affect, or the ones that affect most common drugs, like we had mentioned, antidepressants, antipsychotics, statins, okay? So some of the genes that we were talking about, or that we wanted to highlight, are the CYP2C19 gene. So this particular gene, it encodes a cytochrome P450 enzyme. So that's what the CYP stands for, cytochrome P50. That's part of the family of enzymes in the phase 1 detoxification pathway that happens in the liver. And it metabolizes at least 10% of the commonly prescribed medications, including things like proton pump inhibitors, antidepressants, antiplatelet agents, benzodiazepines, anticonvulsants, tricyclic antidepressants, things like that. So when we're talking about the CYP2C19 gene, it really deals with over 39 alleles that influence enzymatic activity. And variants of that gene can result in different metabolizing phenotypes. So you can have like a poor metabolizer, you can have an intermediate metabolizer, you can even have more of a rapid or ultra rapid metabolizer. And this is where people can metabolize those drugs very quickly and make them less efficacious, or where they need to have higher dosaging. So all of these things really impact the way that a doctor would either prescribe that drug or not at all. So it's really important, especially for drugs. I mean, for the CYP2C19 gene, for drugs like what is it? Clopidogrel or
Clopidogrel, which is Plavix, an anticoagulant.
There you go. So these, for poor metabolizers, they may not activate the drug effectively, reducing its efficacy. Or for proton pump inhibitors, poor metabolizers have much higher drug exposure, which could increase the side effects. So these kinds of things are very important to know and can affect how that drug is taken.
So I want to take a step back.
Mm-hmm.
So we process our drugs through our body a few different ways. 1, through the liver, 2, through the kidneys, 3, sometimes in the gut. They either have to be broken down and converted to a new form, so we get an inactive form that becomes active, or it goes in and is broken down, and then that metabolite has something add onto it or broken off, and then we can utilize it better. So the reason your DNA is so important is, as Dr. Varden said, in the case of the CYP2C19, it is the first pass in the liver. The liver, you often go through 2 different times. If you don't know, do I have a fast first pass and a slow second pass, or do I have a fast first pass and a fast second pass? If you're going through it quickly, some people can say, I can take all the caffeine I want and I can go to sleep. You know, I can drink 3 cups of espresso before bed and whatever. Or you can say, I can't even take half an aspirin and my gums are bleeding. This is one of the reasons you want to know, what are my pathways? How am I likely to metabolize a drug? Now, is every drug on the report? It's not, because if the drug isn't impacted by one of the key pathways, then it's not going to be on the report. And there may be a different way that it's metabolized that's not through the genes system. So the report is put together with a few key genes that will manage a majority of those that go through, especially the liver. And so in the CYP2C19, 60% of all people have at least a variant that is going to impact some drug that they would take. And I want you to hear that again. 60% of you have at least one component that's going to impact, which means you better know what you're doing. Now, I would guess most of you on here tonight would say, I know, and I think I saw earlier where Marta said, I know that almost every prescription doesn't work for me. Marta, if you don't have a pharmacogenetics report, you need one, because this is going to help you. You've been shooting blindly, and this is going to help guide you through the path. Barbara also said Benadryl doesn't work for her at all, you know, and are there other antihistamines that would work for her? Very likely, very likely. And so those are the kind of things on a day-to-day basis. Now, the thing that I love, because I'm very naturopathic, is yes, we have all the pharmaceuticals. Yes, I'm classically trained in pharmaceuticals. Yes, I work in clinical pharmacy, but I'm always trying to divert people more to the natural path. And we actually have some natural agents on there as well, because just because something is natural doesn't always make it safe. And if you know that things are going down those pathways, or if you know you have kidney issues and you've got to avoid, I want to make sure that you're not only utilizing your prescriber effectively, but I want to make sure you're using your pharmacy effectively. How many times have you gone to pick something up, and more people are doing the drive-through because they're just too busy and they don't want to come inside, but they're like, do you have any questions for the pharmacist? What did 99% of people say? No. Not because you actually don't have a question. You either don't know what question, you don't know what you should be looking out for, you don't know if there's something on your profile that should. What I'd like you to say is there something I should know? Is there something that I should be aware of? What are the most common things I should look out for? Now, many pharmacies will give you a printout that say the most common side effects, the most things to be aware of, but not all of them do. So are you utilizing the resource just like you showed up here to gather information? Are you actually gathering information when you go to pick those drugs up? Or it's just like my doctor says I should, so I'll try it? Because I want you to know what an underutilized health professional, a pharmacist, tends to be, because people think of lick, stick, and pour. And yes, there's a lot of background where things are pre-screened, but every day, for example, today, I had a young woman who came in who was on rosuvastatin. You heard the word statin. So statin, she's on a cholesterol medicine, but she came in with a fungal infection. So now she's on fluconazole. A lot of the girls here may have said, oh, I've been on fluconazole, got a yeast infection, had a little antibiotic, got a little itchy, so the doctor put me on that. Rosuvastatin and fluconazole interact. And when they interact, It's going to lower the statin and up the fluconazole. Well, you may not want your fluconazole to be 1.5 times more effective, because anytime you have an antifungal, you can get really dry. Your eyes can dry out, your lips can dry out, your mucous membranes can dry out. A lot of times it's one day. Okay, you can live one day. This woman has had this recurrent gone on. She's going to be on this drug for 7 to 10 days. Fortunately, I was able to catch her and say, make sure you stop your statin for 10 days. So if you're on the drug 7 days, fluconazole lasts for 3 days. So go 3 days past your last pill, then start your statin again, or you may have some side effects. Now, there were 2 other pharmacists that were present today. And I said, if either one of you get this patient, I want to make sure you do this counsel. And they both went, huh? And I said, well, you know that the rosuvastatin increases the efficacy. Did you see the little red flag? And they're like, oh. And it's not that they didn't care, but it was, they just figured, well, a little extra fluconazole might be okay. Well, because I deal with nutrigenomics, because I deal with clinical care and not just lick, stick, and pour, I want you to know that utilize those pharmacists and say, what should I know? How should I know? Or I notice I'm feeling X. Could that be anything here? Because maybe it is. Maybe you haven't put the 2 and 2 together, but if you ask, hey, with the other things on my profile, they will stop. They will pull their profile up and they will look and they'll say, no, I don't see anything that does it. Or, you know what, you might. Please call your prescriber and check that with them. I want you to be empowered to take that back in your hands, because you just don't know.
Yeah, I think there's also a lot of connective tissue between just the DNA 360. I mean, you use a really important word being resource as well.
Hmm.
And it's like, for example, if someone's on a statin, well, we know that this is the reason why they were prescribed that, but we also know some of the areas of the body that it can have an impact on in a suboptimal manner. Like, for example, testosterone production or, mitochondrial toxicity, even brain function. Well, we can go ahead and use the DNA 360 and sort of couple that and go, well, you've also got suboptimal BDNF. That could be a problem for cognition. You've also got suboptimal SOD2. So we've already got some issues at the mitochondrial level. And maybe you've got a really balanced hormone profile and you're not making a lot of testosterone in the first place. We can kind of zoom out, right, and use it as a whole map and say, well, these are the areas physiologically that you're already got red flags, medication aside. Right. And then if we add a medication that might also impact these areas deleteriously, well, now we've compounded the problem that much more, So it's like, I think that all of these diagnostic tools together act as real guiding principles. Like, you can really end up with a way better plan. And all we're trying to do is create the best case scenario, right? Like, I would love it if you didn't have to take any medication, but there are people that no matter how much I say, do breath work and take vitamin D, some people's medical issues aren't going to be resolved because they're just too advanced. So that's where pharmaceuticals do have a role. Like, I'm not anti-pharmaceutical. I think some people think I am because I'm all about primal this and ancestral that. But let me tell you, I can't fix everything with primal. And in those circumstances, yeah, pharmaceuticals are the way to go. But let's at least make sure you're using the one that's the safest for you and the one that's going to work the best.
Right. I mean, I really think about the foundations. It's like figuring out, well, what triggered that? What triggered the need for the statins? Cleaning up the foundation, looking at those basic low-hanging fruit type changes that can be made, because if you do happen to be on a statin, maybe you could eventually get off of it, working with your prescribing doctor, with another practitioner to help you go through this to see if that's even possible. But why not clean up your terrain the best you can to make what you are taking most efficacious? Getting the body as healthy as it can be. And the nice thing is Justin, you were saying about the crossover, the information between the pharmacogenetics and the DNA 360. Well, the gene we're talking about that affects statin metabolism is the SLCO1B1 gene. This is found actually in your DNA 360 report under the cardiovascular profile. It's obviously in the PGX report as well, but here we've got a nice crossover that can at least give you some initial information in your DNA 360. Then if you want to know more information, having a PGX if you haven't already done it. But that SLC01B1 gene, it encodes a transporter protein that's located on liver cells. It is responsible for moving drugs, very much and notably statins. It also moves endogenous compounds. These are compounds, things like bilirubin, hormones. And what I mean by endogenous means that it's made inside of us. We're not taking it outside and bringing it in. That would be exogenous. Okay. And what it does is it moves these drugs and these endogenous compounds from the blood into the liver for metabolism and elimination. Now, when you are talking about different variants, okay? So the SLC1B1, a C allele is actually suboptimal. The T allele is more of the normal, regular encoding of that transporter protein. So if you have a C allele, that means you have a decreased function, or if you have a CC, that's poor function. So you're making little or no transporter proteins, which can lead to higher blood levels of drugs, especially statins. It can increase risk of side effects, which can include statin-induced myopathy. So, this is something to be aware of. So you can look at that. And if you are thinking about going on a statin, you may want to reconsider and speak to your doctor about that. Maybe see if you can lean in more on lifestyle, diet, toxin exposure, things like what Justin was talking about, where you can shift and help with that cholesterol, LDL, et cetera, management. So
I want to stop you for a second. For
yes.
those people who don't know the word myopathy, myo means muscle, pathy means pathological. So muscle issues. One of our biggest things that we are concerned about is another big word called rhabdomyolysis. Rhabdomyolysis means those muscle tissues will literally snap. So one of the things that I counsel when I'm counseling my patients is if you are walking or moving, excuse me, I'm a cough, and you feel like you get a Charlie horse, stop immediately. Because once you're on a statin, you may develop this catch and then the muscle tissues break. I have actually had a patient who was a runner. His cholesterol was high because he was under a lot of stress. Cholesterol goes up the more stress you're in, because cholesterol is actually an antioxidant and it's protective. It protects the brain, it protects your hormones, it helps your cells. The reason the cholesterol goes up under stress is the body goes, oh my gosh, there's so much stress. The brain is under all this pressure. So cholesterol shoots up. Most traditional doctors will say we've got to pull it down to that safe level. So this runner, this ultramarathon runner, went on a statin, started having all sorts of muscle pain. He was used to having pain because he was a long distance runner, but his muscle snapped in the middle of one of his races. He went down and he literally had to go off the statins, had to change his diet, had to have his muscles reattached. So when I am counseling someone on a statin for the first time, I say, cholesterol does three things. It protects your brain, it protects your hormones, and it protects your cells. Now, is all cholesterol good? No. Okay. Is all form of fat good? No. So you've got to pick and choose. But if your brain starts to go down, if for women, you start getting all sorts of hormone issues like hot flashes or sweating or terrible moods or vaginal dryness, you need to talk to somebody. If your skin doesn't repair, if it takes forever for your nails to grow and forever for a scratch to heal, you may be getting your cholesterol too low and your body.
Oh, she froze. Okay, so
Monopoly problems.
yeah, so kind of following up with some of what she was saying is that the importance for cholesterol, we need cholesterol. Cholesterol is very important. It is the parent compound of all of our sex hormones. It is absolutely necessary because in your cell, there's a bilipid layer for the cell membrane, okay? And they have these trans proteins, and cholesterol is part of that membrane. It helps keep the cell fluid and being able to move and do the things that it needs to do. So we don't want to lower and get rid of all of our cholesterol, for all of those reasons that Dr. Nielsen was talking about, that you are going to have problems. So again, it is a matter of paying attention and making sure that you are at the levels that your body needs to function properly, to be able to heal. So, again, cholesterol is not the enemy. It is very, very important. We just don't want it to be so far out of range where it is causing problems.
Yeah,
Like
well, and also, sorry, Dr. Laura, I was going to say also the cholesterol that you eat is not necessarily correlating with blood cholesterol levels, right? Like your body creates cholesterol and it does it for a reason, right? Like your liver makes it, and it's really something that gets dispersed in response to inflammation, right? Because it helps heal the inflammation in your body and in your endothelium. And when we have a poor inflammatory response, or just we have too many things causing inflammation, and then we have a lot of different toxicity entering the body as well, or the body doesn't have good detox pathways, then it basically makes it so that the cholesterol isn't able to efficiently be dispersed and then pulled back to the liver. So it'll remain elevated. But the issue isn't the cholesterol. The issue is that you have inflammation and toxicity, and it's hardening and it's causing plaque formation. So LDL specifically is remaining elevated. I mean, we've also got things like PCSK9, for example, which influence LDL receptor sites. So there's a whole map associated with just cholesterol, but just understanding the purpose of it, because I will say statins, I think, are one of the most heavily prescribed things out there. And usually just learning how to eat and improving your detox pathways and different things can help manage that issue way better than a statin can, just because there's no other bad effects. I mean, there's no reason not to learn how to eat. And when I say learn how to eat, I mean eating in concordance with your genes and the things that are going to work well. I've seen people take like a lower dosed statin and had it function pretty well just as a bridge while they were resolving the issue itself and improving detox and lowering inflammation and things. But I think also another part of the issue is that when you get prescribed some of these things, including statins, the dosage is like higher than it needs to be right off the bat. Like I've seen that pretty often as well. And it's like maybe a low dose statin isn't the worst idea for a lot of people, but perhaps the dosage itself is in fact the poison in that case.
Yeah, interesting. Maureen in the chat is saying that when she was on a statin, she couldn't raise one of her arms above her shoulder and her mom had weakness in her legs. This is what Dr. Nielsen was talking about. Because the cholesterol levels were lowered to such a point that you were not getting enough for normal or even optimal functioning for the healing process. Because as Justin was saying, cholesterol being very important, it is acting like a salve, especially on the endothelial lining when you get microabrasions due to toxins. And the thing is that I tell my clients this, that cholesterol cannot move through the bloodstream on its own. It needs to be taxied. Well, LDL cholesterol and LDLs, because it's the cholesterol that attaches to it, and HDLs, they are the taxis. They are what goes down to the liver, gets the cholesterol, brings it to the site of inflammation, slathers it on in order for that healing to occur. And of course, if you have more microabrasions, more inflammation, well, then you're going to need more cholesterol. Therefore, you're going to need more taxis. So instead of just going, oh, hell, your cholesterol is too high and your LDLs are too high, let's throw a statin at it. Well, why don't you figure out why you need more cholesterol? This is what functional medicine, functional genomics is all about, is really getting to the root cause of why is this happening? Now, maybe, like Justin was saying, you might need to take some statins in the interim to kind of help with that, so that way it doesn't cause any more damage if it's too high, while you are cleaning up the diet, while you are figuring out what that root cause is causing all of that inflammation. So it's really understanding what the pathways are, what the reasonings are, educating yourself about what is really going on in the process. So that way you can make better decisions.
Yeah, well, and understanding how the whole system works there. I know we're spending a bit of time on statins, but that was the biggest answer in the poll. So the other thing would be like, let's say you do have a 4 allele, right, in the ApoE gene. I mean, that represents a decreased ability of your body to use the cholesterol for the healing of that inflammation as well. And it gets compounded if you have suboptimal nitric oxide genes. Like we look at the NOS3, like ENOS, we call it, because it's endothelial. And so if you don't have enough sheer blood flow in the first place, and then you have the 4 allele in the ApoE, and then you have other things that are causing inflammation, like you have suboptimal detoxification and suboptimal anti-inflammatory genes. Well, now the cholesterol is being dispersed. It's more likely to harden because of the 4 allele. If you have other toxicity issues, it's that much more likely to turn into plaque. And yeah, you're going to have a pretty good likelihood of that cholesterol not being on an efficient cycle, distributed from the liver, deal with the inflammation, pull back to the liver and going back around and around. And then you take a panel, and of course, there's all of these elevations in the panel, but it had nothing to do with a statin deficiency, right? It has everything to do with toxins and inflammation and suboptimal genes within the system. Hi, Dr. Nielsen.
Welcome back, Dr. Nielsen.
Like in the country and having a rainstorm.
Oh, there we go.
Like electricity went out.
Yes. I'm glad it came back on. No, you're all good. We covered well.
I have no doubt. I have no doubt.
Actually, I wanted to get to the third main gene because this covers one of the other main drugs that people either are dealing with or friends, family that are on, and that is for pain meds. And the gene I'm talking about is the CYP2D6. Now, the function of this gene metabolizes about 20 to 25% of all prescribed drugs, and that includes antidepressants, antipsychotics, beta blockers, opioids like codeine and tamoxifen. So when we're talking about genetic variations, it's a highly polymorphic gene, meaning that it's got a lot of different structures as far as, okay, trying to like de-nerd this a little bit. It's got a lot of different, actually over 170 known different phenotypes or haplotypes, where phenotypes include being a poor metabolizer, intermediate metabolizer, normal metabolizers, and ultra metabolizers. So what exactly does all of this mean? If you are a poor metabolizer, that means that you make little or no enzymes to have the activity, which can lead to having ineffective activation of these prodrugs, of codeine to morphine, okay? Because that's the enzymatic breakdown that it works on. And it can increase side effects from active drugs. As compared to ultra metabolizers, this is someone who has multiple gene copies, and this can lead to very rapid drug clearance or excessive activation of these prodrugs, which could increase the risk of toxicity. So why is this important? Well, for codeine, okay? For poor metabolizers, they get very little pain relief, while ultra metabolizers risk opioid toxicity. And for antidepressants, antipsychotics, metabolizers, that metabolizing status affects the efficacy and that side effect profile. And I wanted to bring up something. Dr. Gutierrez, I'm actually going to have you unmute yourself, because you had brought to our attention incredible information before we started this webinar, specifically about codeine and pregnancy. Would you mind giving us some of that information so that way they can hear?
Yeah, definitely. Thank you guys. Thank you everyone for joining. I have to say that pharmacogenomics is one of my passions. Primarily, I'm a patient advocate. So this is one of the best ways that we can ensure your safety, give you guys an option or give you guys the opportunity to advocate for yourselves in these very stressful clinical situations like Dr. Varden, Dr. Nielsen, and Justin were saying at the beginning. But codeine specifically, so it's metabolized by CYP2D6. Codeine's a prodrug, so it needs to be broken down before it can, offer any relief to the patient. With ultra rapid metabolizers, they're at risk for an opioid overdose due to extensive conversion to morphine. So when the overproduction of morphine, it can decrease CNS effects. So you get that respiratory depression, you get some of the, cognitive effects, and then this is more important specifically with women that are breastfeeding. So infant deaths have actually been reported because mothers that are ultra rapid metabolizers of codeine, they, take the codeine. It's a very common opioid, kind of one of the lighter taken ones. So they'll take it and then they convert it quickly to morphine, and then it passes through the breast milk to the baby. And then the baby ends up overdosing from the opioid. So it's one of those things where there's not a lot of information about it, but it is something that is detrimental and that people need to be aware of before they take these things, especially when it comes to the babies. So yeah, that's
And
one of the ones
a lot
that
of people don't realize that like their cough syrup could have a codeine in it.
exactly.
Or it's not just like, oh, somebody's going to go take plain codeine. It's mixed with other things. Or it's like, so I have a temporary prescription because I had a C-section and naproxen isn't holding me. And so maybe they give you some short-term Vicodin, and that hydrocodone can get metabolized, and mom's still wanting to breastfeed. And like Dr. Gutierrez said, these are super innocent, but it's often the innocent and ignorant go together because someone just doesn't think about, well, what are the genetics of this mom? I mean, she just went through this whole traumatic birth or whatever, or she's struggling. Maybe she was in a car accident prior to delivering and now she's delivering and she's got some chronic pain. These are the kind of things that you just don't know, that you just don't know. And we just don't want to see any of you hurt. So I also love it that if you get your test and you see that you have this tendency, you can also not guarantee, but you can say to a family member, whether it's a parent or whether it's a child, hey, I have this tendency, you might as well. And so somebody's got to be the place that starts it. And if you're on here, you're proactive. And that's why we want to take the time to say, we want to give you that $200 off so that you're proactive and you start a line of information. Let's test, not guess with your medicine anymore. Let's test, not guess with your children's future or your grandchildren's future, because it's important that you know what are my tendencies and the tendency for your family.
So we are coming at the top of the hour. So I would like to get to questions because we have a lot of wonderful questions in our Q&A. So our first question is from Susan. And she's asking, I looked at the sample report, but did not see gabapentin. Is it included in the report? If so, can you tell me where it is located or if that type of medication is listed under a different name? If it is not on the report, why not? Isn't it a common medication? So first of all, gabapentin is a anticonvulsant. And
no, gabapentin is used for nerve pain. It's used in chronic pain where nerve innervation is innervated.
Okay. So, I mean, it can also treat seizures, yes, as well as pain.
Very rarely do we use it. It's really used more for nerve pain.
Gotcha. Okay. So I did look up to see if it was listed in there. I did not find it. But again, as Dr. Nielsen had said, these not all medications are listed. And I mean, when you consider the physician's desk reference, which is this huge book that lists like all the medications, it is like a huge Bible. And there's no way that we can put all of those in there. And as she had mentioned, there are also things that that don't get metabolized by some of the genes that are being tested. So that's probably one of the reasons. But, you know, being or acting as an anticonvulsant, even though, as Dr. Nielsen has stated, that it is rarely used, but, you know, can be used. I did look that up, and we do have anticonvulsants listed. Different drugs under that is lacosamide, these pronunciations, phenytoin.
Phenytoin.
Yep. We do have a small handful. So as far as nerve pain.
So Dr. Varden, one of the things I just looked up was the mechanism of action, because it works at the end of the nerve receptor where one nerve touches the other nerve, and it works gabapentin. It works on the GABA receptors. It's really more at the site between the nerves, and we're not looking at the liver and the kidney metabolism. It's how much can stay in that nerve area. And I'm just trying to see if I can see what its method of elimination is to give us an idea.
Yeah, because you know, just doing a quick check on this, that it looks like in humans it's really not appreciably metabolized.
Yeah, it isn't, and you have to use it 3 times a day because it's so quick.
Right.
Yeah.
So yeah, unfortunately, I mean, they do have some studies on the metabolization in animals, but not so much in humans. It's more of transport and response. So that is why. Thank you so much for that assist, Dr. Nielsen. You are awesome. This is why you are the doctor of pharmacy.
Well, this is why we do teamwork. And
absolutely. All right. So Susan has another question. She says, on the sample report under genetic summary, there are some genes that are listed as not tested. Why are they there if they are not tested? Or are they supposed to be listed there and there's a specific reason they are not tested in this person? That's a good question. I do not have a definitive answer on that. We can certainly look into why. I would surmise that some of those may be due to in sampling and testing that I know that I have come across people's reports that I have gone through that some of them, they say indeterminate. So maybe there was something in the testing that, you know, it didn't read, or they, you know, couldn't determine as clearly, because in other reports, it does show the genetic variant. So, but actually, Susan, that's a very good question. And we will have to speak to our Chief Scientific Officer, Dr. Kosterman, to get that information. So if I could ask either Katie or Vanny to highlight that question, to keep it aside, so that way we can get that answered. Thank you.
Yeah, I also know that, sorry, the more genes you test for, the more price point trickles down to the consumer. And if it's not entirely necessary, they're not going to do it. Like, same with the DNA 360, right? I mean, the entirety of the human genome is way bigger than the, you know, less than 100 genes that we actually look at. But the ones that were selected were very much selected for a reason. And the more that you add, the more that the cost is to actually test and look at them. And if there isn't like concrete evidence as to this is going to be clinically relevant, they're not going to include it in the report. But as to why it's worded that way on the PGX, then yeah, I would say Dr. Kosterman will hopefully highlight that for us.
So our next question, actually, we've got a few of them from Shelley. And she says, will insurance honor the results from the PGX test, or will the insurance companies make you try less expensive meds first? Good question. Now, we do have on our website that does give some information that if you are a US resident with private health insurance, your PGX might be covered. And really what it is that because it does offer significant benefits in personalized medication management, it's really a matter of checking out your insurance coverage because the health industry increasingly recognizes the value of precision medicine in improving patient care, reducing healthcare costs. So private insurance providers may consider covering the PGX test as part of their benefits package. So it's
I
always—
think there was another part to that question, and I don't have it on mine, so I can't see it. I think she was saying that, like, if rosuvastatin is what she needs instead of atorvastatin, would they honor the results and do the rosuvastatin? Was she talking about the test, or was she talking about the agents that we recommend on the PGX? Because what I will tell you is they will not honor those. The way the insurance works is they have a formulary, and they have tier 1, tier 2, tier 3, tier 4. If atorvastatin is the tier 1, they're going to say you have to go and fail. And then your doctor has to say, she tried it for 2 months, she failed, she had these side effects, now we can try. Now, the good news is you can take your PGX to your doctor and ask for a PA, prior authorization, and say, my genetic predisposition is I will fail on this, and therefore I should be allowed to not have to go through 2 months of side effects and failure, and be able to use the agent that is most compatible to my body. Then what happens, it goes to the insurance company, and then the insurance provider goes thumbs up, thumbs down. Now, so that you also know 20% of them, they automatically fail. You go through and you say, why are you failing me when I have a genetics test that shows that atorvastatin is the worst one for me? So it's a little bit of a going around and around, but they will make you follow that pattern. But providing this, your provider can add that as during the prior authorization, the data on why, and then they can't fight you. So I love that Dr. Lara said, will they pay for it? Yes, no. But then can you get them to do the drugs? Yes, no. Kind of a little bit of both.
such definitive answers. Yeah, it's kind of like one of those things. Well, it depends.
Yeah. Keep
So-
pushing is what it is. Advocate
Yeah,
for yourself.
and honestly, dealing with insurance companies, they seem to have this habit of denying, first off, I mean, denying enough where it saves them money. So be persistent. Don't
Yeah.
take no for an answer. If you keep, going, hey, why? No, I want to do this. Your likelihood of having something covered, is better. So don't think that, the first time that you're denied, it's going to totally be denied. Anyway.
Yeah. Well, it has to be deemed medically necessary, right? But if that's up to the eye of the beholder, because to me it is medically necessary if it's my body we're talking about, right? So it's one of those things where you got to, just like Dr. Laura said, be persistent and keep going, because if there's even an off chance that they are going to help you along with that, then you might as well keep pushing.
Well, and I love that Dr. Gutierrez just put in as kind of a note for us, Medicaid is now paying up to $1,000 for a PGX test via medical necessity forms submitted by the doctors. So this is what I was just talking about, those prior authorizations, depending on the health system, depending on the contacts, and depending if you've continued to fail in other areas, then you say, doc, we got to get one of these PGXs so I don't have to continue to fail, and you don't have to feel like I'm always going to be the one patient that doesn't make it, So what a great way to be able to, again, advocate for your physician. And if they go, I don't know what a PGX is, you say, great, well, I have one. And you know, health providers are always welcome to call the DNA company, and we can put them on with somebody like Dr. Gutierrez and walk them through. And then we can always, when they get so excited about, oh my gosh, I didn't know this was available, we can put them on with Dr. Varden and talk to about having them go through the DNA University so that they incorporate more of this genetic testing into their practices to serve you, their patients. And then you are the impetus to make your clinician a better provider.
So another question from Shelley, she says, or asks, does the PGX report cover supplements too, like melatonin? And this is what I had said at the top of the webinar, that unfortunately, the PGX report does not cover supplements. So no, but it does obviously cover many of pharmaceutical medications. And remember that I also said that it doesn't cover drug-to-drug interactions, things like that, or lifestyle. It doesn't take that into account either. All right, so we've got our next question from Cindy. And she's asking, does your report warn people with mold sensitivity, HLAs, not to take penicillin, amoxicillin? Okay, this works into the answer that I just gave before, that this test is only informational to your genetics strictly, not lifestyle, not toxic exposures or interactions, anything like that, because it doesn't have that information, you know, unless you had filled out, you know, or, you know, there was part of it that does like a full intake and works through all that, but that's not what the test does. That's not where its strength lies. It's strictly for your genes and how they metabolize certain drugs. So really, when it comes down to wondering, Cindy, you know, for the drugs and if someone should take that with mold sensitivities, HLAs, things like that, this is where you work with a practitioner who has knowledge, experience, and information on how to navigate all of that information together, which we have here. So our next question is from Maria, and she is asking, does this test tell me exactly what meds work, don't, or is it a general category and I have to search specific ones myself? This actually, it's separated into 3 sections, and they do group major testings, but they list the pharmaceuticals specifically. So no, you don't have to go searching for yourself. But like I said, it's not like it has the whole pharmacopedia, you know, of all drugs out there. So
but it is set up like a stoplight. We have green, we have yellow, and we have red. So green is things that most likely will agree with your system. Yellow is based on your lifestyle, based on other parameters, may work, may not work. Red are the least effective or the highest likelihood of having side effects. And those are the ones you want to stay away from. Yeah, and I know we put a sample report in earlier. Maybe we can put another sample reporter link in there so that people could see a copy of a sample report.
Yeah, and Dr. Gutierrez put saying about stoplight, you know, that is not recommended by MolDX because people will just stop the medications if they see red, and that may not be the case. Sometimes red is just saying, hey, you know, be aware there's something going on, but there can be information for the doctor saying, well, they could use it, but you need to go about it in a very particular fashion. So when you have these pharmacogenetic reports, you should not be making decisions on your prescriptions or on pharmaceuticals by yourself. This is information that you should be aware of, but bring to your prescribing doctor, bring to your, you know, PCP or the hospital that you frequent. So that way there is information that they can discern. You shouldn't be making pharmaceutical decisions by yourself, you know, or with us when we are doing a review. It's only to let you know the information, the strength therein of the report, and then you take that to your prescribing doctor. Okay.
Yeah, and hopefully your prescribing doctor isn't really rigid in their approach or like really brand specific or whatever. Like, having an open-minded clinician is one of the biggest blessings you can possibly have, where they actually listen. And you take something like that to them and they go, "Oh, that's a good call. Like that's something that I hadn't considered." Most clinicians really aren't trained in, functional genomics and, just genomic insights and things. But that report is put together in a pretty self-navigable way, like Dr. Nielsen said. There's the three different color schemes there, and it's a big long list. And within one category, it's going to say this one's red, change may be recommended. This one is just caution, and you may need some extra precautions with that. Or it's green, and it's like the likely result is what's expected there. So it's pretty easy to just share with your clinician. And that's what I say as soon as I talk to anybody about a PGX. I say, like, I am not the prescribing clinician, but whoever is really should have this information on hand. So that's how that kind of works.
Fantastic. Okay, so next question is from Anne. And actually, it looks more like a comment. She says, pharmacists are indispensable. Yes, you are, Dr. Nielsen. She said they prevented. Oh, absolutely. I'm so sorry. Yes, Dr. Gutierrez as well. Absolutely. She said that they prevented a possibly risky situation. 2 different doctors prescribed medications that were contraindicated with her heart medication. So, the pharmacists, caught that and saved her life. So
I can't tell you how many times a day I catch wrong doses. And this isn't about pharmacists. This is why we have checks and balances in any system, is because prescribers are taught to diagnose and make a recommendation. You then have the second step that looks at the whole picture, because they're getting 7 minutes in and out, in and out, in and out. They can't know everything. And so when you've got that second step, I can't tell you how many times I go, this isn't right, or this doesn't make sense, or this could hurt someone, or this. And so we work as a team, and it's only when we work as a team that everybody really wins. But as many of you know, the fourth leading cause of death is medication error. And that is appropriately described medication error. That's not even inappropriately prescribed. So a lot of people just think, oh, my doctor, I say to them, why are you on this drug? I don't know. My doctor said to. I really, really, really want you to say, why am I on this? What can I do differently? How could I change my life? What else is my possibility? What could I try first? I don't know that you remember, but I had cancer at 21. And that their response when I couldn't get my immune system going was a bone marrow transplant. They wanted to wipe out my whole immune system. They said it's like Control-Alt-Delete, because this was 40 years ago. Computers were brand new. And they said, we hope you rebuild. Well, I'm a celiac, and at the time I was also sensitive to dairy. What would they have fed me in the hospital? Jello, which was just sugar. They would have fed me grilled cheese sandwiches. They would have fed me pie or ice cream. Or my mother, who's a diabetic, who was just in the hospital a few months ago, they wanted to give her Sprite. It was sugar, gluten, and dairy. I would have died. They wanted me 3 months in isolation while I rebuilt my immune system. And I said, there's got to be another way. That was $1 million worth of medical debt. And they said, well, you could do nutrition. Go find yourself some little nutritionist, and it'll be 2 years and $2,000 to $5,000. Well, it required discipline. It required effort. It required self-responsibility. But that's what I did. I took 43 pills at every meal. I took 147 pills a day for 2 years. And I lived on eggs for breakfast, and eggs and spinach for breakfast, chicken and lettuce for lunch, beef and broccoli for dinner. And it sucked. But you know what? I'm 62 and cancer-free. I'm 62 and have more energy than most 20-year-olds. I don't live on Red Bulls because I've developed the discipline then. I'm on no prescription medicine for any chronic disease. Yes, I'm on BHRT. I'm an advocate for BHRT. But Justin, something you said earlier, you're a Primal guy. Got myself some Primal, Women's Vitality that was liver and kidney and heart. But oh, by the way, it was uterus and ovary and mammaries and this whole thing. And I'm like, this is so great. Except I'm on stable BHRT and I start having periods because when you take supplements into your body, especially glandulars and hormones, let me just tell you, shit fires up. So I'm on stables and now I'm going, well, do I want to be on glandulars or do I want to be on BHRT? Because I clearly can't be on both because at 62, I don't want to be cycling. I'm not interested in having a period and I am certainly not having a baby. So you have to say, well, okay, maybe I'd rather take glandulars. Now we have peptides, guys. Hey, insulin is a peptide. GLP-1s are a peptide. But those are all pharmaceuticals. Guess what? We have some other peptides like BPC 157, which does massive repair. So maybe you want to look into lifestyle and peptides and foods and, getting back to that primal. What did our ancestors eat? They ate the full animal, snout to tail, and they ate liver and hearts and kidneys, and those revitalized us. So you may not be ready to go to there, but I will tell you that I have cattle raised, and then twice a year I get a whole cow and I get the liver and I get the height. So I got myself a freeze dryer. I see Thomas going, how can I tell the quality? So I like Ancient Nutrition. I think that's a real good one. I like Primal. That's a good one. Justin, who else do you like for organ supplements? Paleo Valley, I like.
Yeah, Paleo Valley is good. Heart and Soil is good.
Okay.
There's other ones that rely more so on bison than just other types of bovine, and those are great as well. I was always a fan of what's the one from the Liver King until he lost his mind. That's ancestral supplements, right? So it's like I have some opinions on that guy because I do feel like he had tons of good advice. And I hate that people throw out the baby with the bathwater because he really was taking a lot of the Primal blueprint and sort of making it his own thing. But then he went and took massive amounts of steroids and then lied to the entire world. And so you got a lot of people saying, well, Primal's nonsense because he did that. It's like, well, no, he actually had a lot of good advice, but he also is obviously a compulsive liar. So use some of the stuff that's good and then maybe not some of the other stuff. But anything that's like New Zealand raised, right? Like places where they have higher environmental standards, those are great. Yeah, Paleo Valley is awesome. And Heart and Soil, I mean, Paul Saladino, he's definitely one of the bigger voices.
Love Paul. In fact, Paul just got put on one of the recent committees for overlooking our FDA and our agriculture and trying to get more regenerative agriculture so that we can start really revitalizing and not be so dependent on pesticides and not so dependent on pharmaceuticals. So we love him with all of that. What I will also tell you, Tom, is I got myself a freeze dryer. Now, this may sound silly, but our livers are about this big. So I don't know how big you think a cow liver is, but I said to my farmer, my rancher, I'm actually not a farmer, my rancher, I'd like liver. And I'm thinking, I'll get 2 little packets of liver because I get all these packets that are about this size of all my stuff. Well, a liver in a 1,500-pound animal is the size of a small tire. Think about the tire in the back of your car. So I got 150 pounds of liver. So I got myself a freeze dryer. Now I do strips of liver. And then with the strips of liver, I dehydrate them so that they become these little like things. And then I put them in my Vitamix and I whir them up into powders. And then I got myself a little capsule and I make my little things. So Tom, I'll send you some liver capsules. I got 150 pounds of liver capsules. Justin, they asked, what's the name of the supplement with your Primal?
Oh, I mentioned heart and soil. I don't think that. So
Heart
the
and
Primal,
soil.
yeah, Primal Health Coach Institute is where I got my actual Primal certification, and they do have a supplement line. I don't believe they make organ supplements, but they do make collagens and things that have other types of peptides in there. And they make Primal Kitchen as well, which is like seed oil free and these kinds of things when it comes to dressings and what have you. So I'm a pretty big fan of all of that.
Yeah.
But yeah, that Heart and Soil is all New Zealand based, and it's you got a lot of different things like the mofo and the her package or something is called, which would have had a lot of what Dr. Nielsen just said. And yeah, they've got like gut specific ones. They've got just the liver on its own. They've got brain. I mean, it's really covering the entire nose to tail spectrum.
Yeah, I like to take not just the liver. I like to take a combination that is heart and liver and kidney. I actually eat menudo, so I eat, the tripe that's in there. Organ meats are super, super rich. If you're going to eat liver, though, or any organ meat, you want a healthy animal. I also live in the Midwest and I live in the Ozarks. And you will see a lot of these big chicken farms where they raise 100,000 chickens in a single shed. And the breed that they do is called Cornish cross, which is white. They raise them in this fake light all the time, and they get so big and fat that within 6 to 8 weeks they take them to harvest. So it goes chick to harvest in 8 weeks, and they will go from chick to 5 to 8 pounds in 8 weeks. It's just so heavy that those chickens can't even walk. And when you look at their fat is very white. Healthy fat is yellow because that's the beta carotene that's in it. So it's interesting because I have a very good friend who is a chicken farmer. He has chicken farms in the Ozarks and he has chicken farms in Virginia, and he goes back and forth every 2 weeks. And I'm like, why didn't you put them all in one area? Whatever, that's a story for another day. He won't eat his own chickens. He sells them to all the major grocery stores, but he buys his special heirloom chickens that, as he says, have yellow fat. He will only eat chickens with yellow fat. So I'm telling you, it is worth it to look at the fat of the chicken and make sure if that skin and fat doesn't have the yellow in it, then even if it says organic, even if it says it was raised inside, because these chickens are so fat, and I've been in these chicken houses because my friend will say, come get some chicks, go get a dozen, go get half a dozen, because I've got 8 or 10 chickens. I start with 24, and then between the coyotes and the owls and stuff, half of them get picked off, but I get 6 to 9 eggs a day. But I started with the corn and crosses and quickly got rid of them because 1, they're not good mamas. 2, they're not good layers. They're just meat birds. And so what you want to do is quality. Sick animal, sick body. Healthy animal, healthy body. And look at again, I've got another friend who's from New Zealand and actually sells a green mussel oil, but his family raised the sheep and raised the different animals, the bison and stuff, that gets these very high quality, non-toxic organs that you can get and meats that you could get. New Zealand quality is really pristine. Their waters are beautiful. So I definitely believe in what Justin's saying. And you want whole spectrum. You don't want just a single organ. You are not one organ. You're multiple organ systems. So do multiple organ systems. Unless, of course, you're on Women's Vitality and taking bioidentical hormones, and then you need to go get all your hormones checked.
Well, we are coming to the end of our time here with just another minute or two. And there's one question that I saw in the question and answer that I really would like to answer. And it's by Rachel. And she's asking, are there similar tests to our pharmacogenomics test that test for vitamins and supplements? And actually, In a way, yes, our DNA 360 does
Yeah, I was
that.
going to say DNA 360.
Gets into nutrigenomics. It's that nutrigenetics, the looking at how does your body metabolize, process, and utilize the vitamins that you are taking in. And yeah, absolutely. Justin even had mentioned a couple earlier, but when you're looking at the methylation pathway, those are your B vitamins. Okay. We have a full pathway for your vitamin D. Okay. We've got a gene that looks at your vitamin A, E, C, magnesium, all of these different things that we can see in your reports to help you determine what you may need and what might or might not work well for you. So absolutely make use of it.
And I just actually wanted to answer one that I saw Diane said. She said she was shocked that she saw some minor thickening and she was concerned about plaquing and what can be done. So a small amount of plaquing most of us have. Plaquing is calcium. It's calcium accumulation. Calcium can be diverted back into the bone with vitamin K2. So look at your seed oils, look at your omega-3, omega-6 balance. You were discussing lipase, nattokinase, pycnogenol. I am not aware that any of those are going to help with plaquing. Those are going to help with clots. Okay, those will thin out your claudication. But if you can do either look into chelation, look into vitamin K2, K1 is the clotting, K2 takes. So look at your vitamin D levels, look at your K2 levels, and you need to drive that calcium back into your bones where it belongs and out of the soft tissues. You've got a soft tissue accumulation.
And with that, I want to say thank you, everyone, for joining us this evening. I want to thank Katie, Vanny, Dr. Gutierrez. You guys are amazing. You keep this all running in the background. We really, really appreciate you. And to my co-hosts, Dr. Nielsen and Justin, thank you again for a fabulous webinar, for this great information. And we hope that we have been able to provide more information to you, especially for those who said, yeah, I'm not quite ready to get a PGX. I need to know more. Or maybe for those of you who said, no, maybe we've piqued your interest and maybe you want to look into it. So, and for those of you who already know a lot about it, we are so glad you are here to further educate yourself, to empower you, to take that agency back so that way you are the master of your own health. So with that, thank you. Have a beautiful day, and we will see you at our next webinar. Thank you, everyone.
Thanks, everybody. See you
Take
next
care.
week.
God bless, guys. Be well. Stay healthy.